Hello everyone and welcome to the first MedTalk webinar of 2025. What are MedTalks? Career conversations by the doctors, with the doctors and for the doctors. And here you have 3 generations of doctors. Welcome sir. So I welcome Dr Shirish M Hastak on the show. He is the Regional Director of Neurology Stroke at the Gleneagles Hospital, Mumbai. Sir has been the past president of the Indian Stroke Association. He has been acknowledged by the India Today 7 times in a row as a top neurologist. For his innovative initiative, Walk with the Dog, he has won the Pathfinder Award. And very recently, Sir has been conferred with the Lifetime Achievement Award by the Madras Neuro Trust. And I can go on and fill up this entire session with only Sir's accolades. But I think I'll stop there and hear it from the man himself. Thank you so much for coming, sir.
Thank you, Dr. Geeti Chadda, and thank you, Metropolis, for this opportunity. And I look forward to interacting with you and of course, with the whole team that you have.
Thank you for coming, sir. And I know you've just come straight after seeing your ICU patients. I realize how busy you are, but we'll make it worth its while. And I'm sure this conversation will help many young clinicians, or rather help many young doctors to become astute clinicians like you. And yes, Keyur. So we have Keyur Sabnis, who is in 3rd year MBBS. He is a young, dynamic, budding doctor of MedEngage research grant winner. Welcome, Keyur.
Thank you for having me, ma'am. It was my pleasure to be here, and I extend a heartfelt gratitude to Metropolis Foundation.
Most welcome. So I think what the viewers will really benefit from are young doctors, that how did a man, a boy, become this celebrated neurologist that you are today. How has this journey been for you? How did you even reach where you are?
I come from a Fauji family. So my father was in the Air Force, my brother was in the Navy, and my uncle was in the Army. But of course, this having this Fauji family also helped me in the sense that we always put knowledge as number one. As they say, there is muscle, money and mind. Yes. 3 power kegs of this world. But my family always put the mind as the key in your life. So my father always encouraged me, and at every dinner actually he used to sit and ask us, so what have you learned today? What is it that you have read in the newspaper that you want to convey? And so it was like a family with knowledge as the key base. So that's how it all started. And initially, honestly, I wanted to become a pilot. If you ask me. But then I think my father had seen too many pilots, get into trouble in their lifetime. So he said, anything else but a pilot, Shirish. I cannot have you become a pilot. So anyway, I listened to him like a good obedient son. And I said my next passion was medicine. So I said, let me take up medicine. And he was very happy. In those days, my family didn't have a doctor anywhere. A doctor used to be always a cherished profession in those days. So I think that's how I went into medicine. And as I moved into medicine, I moved into MBBS in the Government Medical College, Nagpur. Then I moved into MD in the same medical college. And of course, my wife is from the same medical college. So we have a different journey with my wife as well. But at the same time, what happened was my wife and my family, they encouraged me to come to Mumbai. In those days, Mumbai was completely different, Yes. 1986, 87 was a different city, this huge metropolis compared to where I was from Nagpur. But my family said, no, you must follow your passion. And my wife, of course, stood behind me, steadfast. She said, you love neurology, and so why don't you do neurology? The brain, of course, fascinated me all my life. And so when we did MD medicine, you remember we used to have one long case.
Yes.
And that long case would usually be neurology.
True.
And so, while I was doing that, I realized that neurology is my love and also is my second love, of course, after my wife. So then I thought, I'll take up neurology. It's a fascinating area as well. Neurology is a part where you do something like mathematical calculations. You tell the patient, where is the problem, what is the problem, and what can I do about this? So you go in that sequence, and I like that sequence. And I also felt that it's the most mysterious organ in your body. Nothing makes you more human than your brain.
True.
So I said, I said, let me take up neurology. And I said, that was the time I decided to take up neurology. Then I came to Mumbai. And when I came to Mumbai, of course, was a different culture completely. Mumbai was a completely different culture than when I was in Nagpur. But I liked it, very professional. And very professional. And Dr. P.M. Dalal, who's my first guru in neurology, was very, very strict person. And in fact, we used to be in the ward at 5 a.m. in the morning, seeing patients, and we'd leave the place at 10 o'clock at night.
True.
And but I really feel that he trained us clinically so well. And so, of course, he would say that, Shirish, I'm not your friend, I'm your teacher. And that was what made us move ahead. And so once I did my DM, he said, Shirish, I want you to do stroke fellowship. And he was, of course, a strokeologist. In those days, probably there were one or two strokeologists in India. So he was one of the first strokeologists in India. He said, I want you to do stroke and do your stroke fellowship. So he recommended me to Canada to do my stroke fellowship. So, and Canada, of course, was a big cultural shock again for me. A big cultural shock. In 1989, in India, there were, I think, just 2 TV channels, and there were 100 TV channels in Canada. And there was also this, big difference between India and Canada. So I went from this public hospital, which is Nair Hospital and TNMC, to a university hospital in Canada. And here I was used to seeing, 50, 60, 70 patients. And there it was 5 or 10 patients. And so completely different, culturally completely different. But then Canada was a big teaching experience for me. I really learned lots of things when I went for my fellowship. I also realized that research is important in life. So I was involved in research in the carotid endarterectomy trial, in the Canadian American ticlopidin. Ticlopidin was a big molecule after aspirin in those days. So worked with the Canadian American ticlopidin trial, then the ticlopidin aspirin trial, and I was involved in all those trials. So, and learned a lot from my teachers in Canada, which was Dr. Hachinsky and his team. And then, it so happened that, whether to stay in Canada or to come back to India was a very big decision. Because, as I told you, there were no air conditioning.
Glad you came back.
Thank you. But there were 2 things which influenced my coming back. One of them was a patient.
Oh.
So there was this 70-year-old lady who came into my clinic, and I was examining her, and I examined her, prim and nice Canadian lady. And so she asked me, are you an Indian? And I said, yes, I look an Indian, so I am an Indian. And so she said, why do so many Indian doctors want to stay back in Canada? This was the question she asked me. And she was very candid. But I appreciate her.
She got you thinking.
Yes, she got me thinking. She said, if you guys are so smart, why don't you go back and help your own people back at home? So it got me thinking. And then I went back and spoke to my wife. I said, this is what she asked me. And I think this is a very important question we have to ask ourselves. And so this is, the turning point in my life, like all other people. I mean, those days, staying back in Canada was the common thing done. So when my teacher called me, Dr. Hachinsky, and said, do you want to stay here? Do you want to go back? I said, I want to go back. And that was my journey back, influenced by this patient.
Wow.
Who said, what do you really want to do in life? I think she asked me a very basic question, which I had not probably...
A very profound one, which led you to this.
Yes, which I had not asked myself till that time.
We get so busy that we forget to talk to ourselves.
Yes.
But then somebody gets us thinking.
Yes. So she really got me thinking. And so then I decided to come back to India and set up my practice. So there was always this idea whether I should go back to Nagpur or stay in Mumbai. And then my wife, Meenal, said, no, let's stay in Mumbai. You know, those days there was a big difference between Nagpur and Mumbai in terms of facilities, in terms of infrastructure, hospitals. I'm talking about it's 91. So 89 I went for my fellowship, 91 I came back from my fellowship. So I said, okay, let me try to settle in here. And so when I came back, I also got another idea from Canada, which I also feel was very important to my practice. You know, once a patient in Canada came and sat down, and she was an old lady, and she could not remove her shoes. And so the chairman of my department sat down and removed her shoes.
Wow.
And so again, I was impressed. I said, you know, this is the connect you have to have with patients. You know, you should not be this, you know, apron wearing, you know, tie wearing doctor who doesn't connect with patients. So when I came back, and you know, in those days, I started my practice on Pedder Road. You know, Pedder Road was the
destination.
the destination. Started my practice on Pedder Road. But I told my wife and my family, I want to have a living room style clinic. I don't want to have that clinic where the doctor's chair is big and the patient has a small stool. You know, and I don't want this big, you know, sort of table between me and the patient. And I don't want to wear a white coat.
Wow. Very
Again,
different, sir.
to separate myself from the patient. I want to bridge this gap, which I found, you know, much bridged in Canada. So I came back and I set up a living room style clinic with a small coffee table.
Lovely.
You know, like we have right now between us.
What a different idea.
So that's
I don't think we have too many doctor clinics like this.
I set up a clinic which is a living room style clinic, and I said, let me actually try to bridge this gap between the patient and the doctor, and try to help people more by being closer to them. And all my life I've tried to sort of do this. So after that I set up a stroke support group, again to bridge the gap. Because you know, once a patient asked me this question, Doc, you've been giving me medicine for 5 years and my right hand and leg hasn't improved. You know, no one spoke to him that the medicine is for his left hand and leg not to get a stroke. No doctor spoke to him for 5 years.
Oh God.
So then I realized that we still have this gap. So then I set up the stroke support group, ran it for about 15 years, and then got a little bit bored with it, you know. You do get bored with if you keep doing the same stuff over and over. And then in a creativity conference, a person called Rajeshri Menon came up to me and said, you know what, Doc, why don't you do this idea called walk with a dog? Why don't you do walk with a dog? And this is a different idea. So I realized that why don't I help medicine in general, rather than only helping stroke and neurology and my passion. So then I said, okay, why don't I move this stroke support group to walk with a dog group? So I shifted it to walk with a dog group, and walk with a dog has a pretty simple idea. So educate, exercise, empower. And in those days, exercise was also coming in a big way, you know, as a health, you know, preventing of disease and a health initiative. So I said, why don't I do this? So 7 years ago, I said, I'll walk with a dog. We've had 70 walk with a dog to date. And we've had 70 different doctors come in.
Lovely.
So it's either sometimes a cardiologist, nephrologist.
So very diverse conversations.
Yeah, you know, physician, transplant doctor, you know. So and every first Sunday of the month, we do walk with a dog. So that, you know, we try to bridge this gap between the patient and the doctor.
Wow, sir. No wonder you are where you are, right, Keyur? Lots of learning over there. So it's very interesting, you know, while you were speaking, it was so much similar to Metropolis Foundation. And, you know, when Dr. Sushil Shah, who's our chairman, he started this, you know, it's very interesting when you say about empower, educate, include, diversity, take feedback. You know, that's how it started. So I remember, you know, I'm from Armed Forces Medical College. I've done my training from there. Very empowered, entitled in terms of infrastructure. And, you know, Sushil sir was at JJ. And he said, no, Kirti, so many colleges do not have so many facilities which our doctors need. So as you said, no, you thought for the patient. He was thinking for the doctors. And he was like, doctors don't have anything. Doctors don't have this. Doctors don't have that. Can we make a program that we can help the doctors, you know? They want to do research, they can do research. They want to, publish, they want some mentorship, they want guidance. They want to have this kind of conversation. Today, where does a doctor get to have this kind of conversation? So this whole MedTalk also, it's basically just career conversations by the doctors, with the doctors, and for the doctors. This whole concept of taking feedback, bridging gaps, educating others, empowering others, I think it's so wonderful that you've done it. And I think the 3 takeaways, if we can take from Sir's thing: 1, knowledge, keep knowledge above everything. Knowledge can overcome anything, actually, any barrier. So that is the first thing, and all of us doctors are addicted to it, and nobody who does not want to improve their knowledge should get into the medical stream, because that's not fair for the patient then, right? So that's one thing. And the second thing which Sir spoke about, Sir, all your 3 major decisions actually came from feedback from patients.
Yes.
Right? So that
yes.
itself is a very interesting thing.
Yes.
And third, bridge the gap. Find a gap, bridge it. Don't just crib that there is a gap. Gap in the country, gap in the hospital, gap in this. You can find a gap. If you can be the person who can change that, you can influence that, then take that on and do it, So thank you so much, Sir. I think there was a lot of learning in there. And yeah. Okay, over to you, Keyur. So first of all, congratulations on winning the MedEngage Research Grant last year. And when I was going through your thing, I realized that it's on stroke, right?
Yes,
which is Sir's specialty. And who would have thought that you would be, sitting next to the stroke specialist? So you want to talk more about this grant and, the whole thing and your study and how did you even chance upon this Metropolis or MedEngage and then did this research? Why did you think of that topic itself? And now how are you, empowered by this, and how are you excited about your path ahead, if you can just share?
So it started back, I think, in my second year when I was actually, we have clinical rounds in the medicine part. So I came across a patient who had stroke, and it was actually it was diagnosed as ischemic stroke and with hemiparesis, complete half body was paralyzed. And I was wondering as to there's no treatment actually. You cannot cure that particular ailment unless it's completely manifested now. So there was I want to do something in regarding this, and I was personally a research enthusiast. So beyond academics, I always liked to do something more. I can't stick to bare minimum when I'm going into medicine. That is something I had. So I was let's do something. And I was just reading about stroke and I think we use Davidson these days. So I came across that there is some kind of association correlation with monocyte and the HDL cholesterol. So I spoke to my mentor and we went through the entire process and we came across that MHR, that is monocyte to HDL cholesterol, this actually can be used to assess the severity of stroke. So this was a novel marker. We had a lot of pilot studies done, but doing that in a tertiary government setup, that was a challenge for me. So I was let's keep this idea in mind, let's see what happens. And the wonderful PR team of Metropolis came up with the opportunity that there's something called as a Metropolis MedEngage outreach program. And I was okay, this is something I want to do. This is a dream come true for me. So I applied for it, went through the entire process, and there was a proper presentation and everything that was going on. And then within a month or so, I got to know that I've won the scholarship. And then it was knight in shining armor for me that now I can do what I always wanted to. And then we carried out the study. It took 7 months for the proper One thing I always learned from this is research is a very ignored area when it comes to medicine in India. Yes, and this actually I wanted to answer in 2 ways. That is, one, if you are someone who wants to go outside, you wanted to go for USMLE or UKMLE. So these are some things that test you for a lot other than academics. Whereas in India, it is more stuck we are having only NEET PG, where it's an objective examination, you have nothing else, they don't test you anywhere other. So that's where research is actually very ignored in our country. And Metropolis actually got me into this, that you have to do, you get an opportunity, why not? And students like me, we are sitting around the entire country and we are we just need that opportunity, and that is where I got it.
When you say this, it's so interesting. When I went to the board with this research grant application, I still remember. And they were now what's this, because see, ultimately we are a laboratory, just doing our work. And I was we should not limit the research to lab. We should open it for all doctors, because it's not a singular thing. See, we look at the lab, we look at the patient from a different perspective in the lab, but the patient is a patient. He's a complete patient. So I was we should open it for clinical sides and everybody should get get access to it. And they were very supportive. Our board was very supportive. The foundation trustees, everybody was very supportive. And you won't believe it, this year 67 people have applied for research. So the numbers have just doubled in a year. That means there was so much need, sir, which was an unmet need, So, and two examples come to my mind. There is this instance in Jammu where a girl heard about this, somewhere far away. As I told you, when you go farther away from the center, people they don't have that kind of infrastructure. And she just heard about it, and she just left some samples with a study at one of the Metropolis centers. And she said that I have heard that Metropolis will take care of this. And she had so much confidence. Yeah. And then I got a call and I said, okay, tell her to submit her research paper. But just imagine that, you come to know of an opportunity, you're sure of what you're doing, you have the guts to, knock on a door and get that. And of course, now she's abroad. She did that about 3 years back. And there is another boy who I remember, Sufyan, who was also, in neuro, sir. Mm-hmm. He had done a lot of work. He was one of our MedEngage champion of champions. Mm-hmm. And today I see him on that Twitter as the influencer on neuro. He's like, so, it feels so exciting because that's what Sushil sir used to say when we started, that Kirti, these people do not have opportunity. We have such bright minds in India, but there is no research mindset. There are no opportunities. Even if they want to do something, either there is no money or there is no infra or there is no, now somebody to mentor them. So when we give them these research grants, we have people, all healthcare luminaries from across the country. By the way, we do not decide anything. So the beauty of MedEngage is that the entire funds are there, but nothing is decided by Metropolis. So we have Deloitte as the partner who, screens all the applications. We don't know who's going to get the award or who's going to get the grant. We are a completely unbiased party. We are just the facilitator, and then when we, take all these, they have to present their pitch in front of the jury. And the jury is leading private and public healthcare leaders who, again, we have just requested. And they do it gratis because we can't afford to spend money on that. We want all the money to go to the beneficiaries. We don't want to spend any money on anything else. So in 90% of the funds which are allocated, which is last year 2.2 CR, went completely to students, completely. So just 10% to, take care of all the overheads, to get the message across through digital, online, so that more and more people get to know about it. And this year again, we have record number of applications. So but it's important for us to hear these stories back to be able to fuel that. So I think thank you and all the best.
Thank you, ma'am.
No, I congratulate you for that excellent work, and Metropolis, of course.
Thank you so much, sir. Thank you. Hope you're able to do it. We won a couple of awards, and because of that, I think other people saw it. And anyway, Metropolis is a leader. Generally, what we do, people tend to emulate. And I was so happy when more and more people replicated this. And today, I'm seeing different hospitals and, different labs coming up with these concepts. And I'm so happy because one Metropolis is not sufficient to take care of all the young doctors of the country. So this is one thing where I'm happy if everybody copies, because that means these many more doctors get access.
Yes.
Because I think the medical journey is so tough and so long, and you see all your friends and your cousins, they start earning and you are still struggling, and no knowledge is good enough, and before you have to clock 10 years to actually even be a decent doctor and another 10 years to be a specialist, and in that any kind of help is good. So I think, and you don't want to really take help, it's just some little support, because you're anyway good, it's not really help, it's just a nudge, a little push and shove, and it helps you get going. So sir, with all this research that we just spoke about so much, stroke is again another area where a lot of research is happening, and there are so many recent advances. So I think our young doctors will benefit a lot by knowing from you, a stalwart, what are the recent advances in stroke, right from the traditional methods to now AI. No conversation is complete without AI. So if you could brief us on that.
Yes, actually, when I started practice 35 years ago, my friends jokingly would say that stroke care is like veranda care, and this was that you put the patient in the veranda and see the fellow the next day, because there was nothing to be offered in stroke. That I'm talking about 35 years ago. Right. But this has changed very rapidly, and over these years it has changed so rapidly that stroke has become, the commando approach to a veranda care to commando approach.
Wow.
So it's like, it's completely changed. And so how it has changed is very interesting. It has changed because, of course, I'm talking about ischemic stroke. So ischemic stroke had this thrombolytic agent come in 1995.
Right.
And up to 1995, I realized that, it was not much you could do for the stroke patient in the acute phase. But as soon as thrombolysis came in, the whole area of stroke was revolutionized. So at the initial part, the TPA or the tissue plasminogen activator was a 3-hour window. Then it came to 4.5 hours window. Then came in the mechanical clot retrieval or the mechanical thrombectomy. And mechanical thrombectomy had a 6-hour window to begin with. Then it came to 9-hour window. Then it came to 16-hour window. Now it's 24 hours window. And as of now, we are even thinking of extending to the point that there's no window.
Wow.
You can treat the stroke much later as well. So this is a fascinating thing that has happened.
Very fascinating, yeah.
That, the whole approach itself has become a commando approach, a rapid approach, like, you are at war. Before it was complete peace. Stroke was a peace area. You could have the phone of a stroke at 2 o'clock and then sleep after that.
Right.
Now you can't sleep after that now. You got to get a phone at 2 o'clock at night. You have to see to it that the fellow is treated in time.
True.
So from that, we set up what is called as the stroke unit. So we set up the first stroke unit in Western India. And then from that, we set up a stroke helpline as well. So I said, we have to have patients come in time, but how do we help them with the helpline? After which we set up the stroke team. So the stroke team approach is very important. So you not only have a neurologist, you have a neurosurgeon, you have a neurointerventionist, you have a neurocritical care person, and you have the neuro rehab, and of course the neuroradiologist. The radiologists are our eyes.
Yes.
They are our eyes. I always tell my neuroradiologist that you are our eyes. We are blind without you guys.
Absolutely.
We are not sure, is this a ischemic stroke or is this an intracerebral hemorrhage?
Yeah. For the right navigation is required.
Yes, so to get the right things in. So once we have that, so now you have the imaging now, and the imaging has become a very strong part of our team. So I don't think there's a single day I have not spoken to my neuroradiologist. I may not talk to my wife that much, as much as I talk to my neuroradiologist. Because the neuroradiologist tells me that this is a patient worth treating, or this is a patient not worth treating. So then of course the MRIs came in, the MR angiographies came in, and now we insist on angiographies on all patients. Because you come to know where is the problem. What is the problem by the MRI, but where is the problem as well by the angiography. And of course CT angiography. Yes. And then we are now started doing what is called as penumbral imaging. So what we do is we have these stroke patients who have a brain which is dead in the center, but surrounding it is the brain which is alive.
Correct.
It's only physiologically gone. It's not anatomically gone.
Right.
So if it's a physiologically gone brain, but it's not anatomically gone, we know there is a penumbra. And this penumbra is the area which is fascinating because the whole treatment of stroke, ischemic stroke, is based on the presence of this penumbra.
Right.
So if you can see this penumbra beyond 24 hours, why not treat this patient beyond 24 hours?
Yes.
Why should we shut down our eyes and say this guy came to us after 24 hours, so we are not going to treat him? So that's the concept of the penumbra. And so I think this is how stroke is evolving. From this, the evolution of stroke is also in terms of endovascular treatment.
Right.
So now a lot of neurologists are doing neurointervention. A lot of neurosurgeons are doing neurointervention. A lot of neuroradiologists are doing neurointervention. So intervention is the next thing to do, which is, you put in a catheter through the groin and approach the clot through the groin itself, and you remove the clot. Now, I'll tell you that one of my close colleagues' husband got a stroke, and he came to me, he could not speak, and his right hand leg was gone. So we gave him the thrombolytic medicine. He was within the 4.5 hours. We gave him the thrombolytic medicine, nothing happened. Of course, we had done his angiography, and we saw that there was a thrombus in his M1. Middle cerebral artery 1 was blocked completely. So we took him up into the cath lab immediately, and we immediately put in the catheter and we immediately removed the clot.
Wow.
As soon as we removed the clot on the table, he said, "Doctor, I can speak."
Wow.
He said, on the table. He said that, "Doctor,
That's so
I can
rewarding.
speak." It's so rewarding. And of course his hand leg recovered completely, and now he's himself a psychologist, so he's active and doing everything. So this is how rewarding it can be.
Yeah.
But you have to have the commando approach.
Right.
You cannot have a laid back approach in stroke. So stroke has become like myocardial infarction,
Correct.
like heart attacks. It's a commando approach. The only thing we had was that stroke is a more difficult disorder to diagnose.
Yes.
In heart attack, it's pain, theek ho jayega, doctor sahab. And a lot of people do that. In fact, they try to do all these alternative things also.
Yeah.
And so by the time they come to us, it's beyond 24 hours, or it's 36 hours. And the penumbra has disappeared. So we need this, sort of this penumbra to be alive. Of course, the penumbra drops over time.
Right.
So you have to remember, that's why this idea of the window. So your chances that you have a penumbra is highest at 3 hours, it will drop at 4.5 hours, it will further drop at 6, further drop at 9, and so on. It keeps on dropping. So it's like, but if you get the right patient, you get the right imaging, you get him into the right system, you can help patients of stroke way beyond what you did before.
Yeah.
So endovascular treatment has come in big, stenting has come in big to prevent the next stroke. Coils have come in for aneurysms. Even flow diverters have come in. Now this is a fascinating area again, flow diverters. So they divert the flow so that the aneurysm gradually collapses, but the artery remains patent. So a lot of new techniques are coming into stroke and into stroke medicine. Having said this, I think stroke has become a fantastic field, and I encourage all youngsters to move into stroke and do stroke endovascular.
Yes.
So become an endovascular person, and you'll be one of the really, one of the top guys in the system.
Right.
Because I talk to my endovascular guys every day. And of course, build teams.
Yeah.
That's one of the key things I have learned in my life is, no man alone.
Yeah.
No man alone. And we are not playing a singles tennis game anymore. We are playing the football game. So the whole game has changed. Since we are playing a football game, everyone is important. And the goalkeeper is as important as the captain. When the goalkeeper leaves the goal, we are in big trouble. So I think building teams is one of the other key things in stroke that we need to do. It's true for all of medicine, it's true for all neurology, but it's especially true for stroke because time is brain.
Right.
And if you lose time, you lose brain. But time is brain is also important. It's the doctor's brain also which is important. It's not just time is brain for the patient. It's time is brain for the doctor, it's time is brain for the system.
Yeah.
And it's time is brain for the hospital as well.
Right.
So all these systems have to be sort of cued in. Another interesting area I thought about was artificial intelligence and the brain.
Right.
It looks like as the brain's mysteries are getting sort of solved, the artificial intelligence is coming up. And there is a big link between brain and the artificial intelligence.
Right.
Now, I'll just tell you a small story about this link so as to, tell people how this link works. So in 1960, there were these guys called Hubel and Wiesel. Hubel and Wiesel were in Johns Hopkins. And they were doing this beautiful research on the cat's brain. So they were neuroscientists. They were doing the research on the cat's brain. And they showed that by stimulating the eyes, by different visual pictures, the image is not processed in one area of the brain. It is processed in 4 different areas of the brain. So it starts in the occipital cortex, like usual, but the occipital cortex only sees lines. So right now, your occipital cortex, my occipital cortex is only seeing lines.
Right.
If you go anteriorly to that, it is only seeing shapes. It's not seeing lines, it's only seeing shapes. You go more anteriorly, it's only seeing objects. You go more anteriorly, it's only seeing faces. This Hubel and Wiesel did in 1960. But this information was not used for 20 years until a guy in Japan, Fukushima is the name of the guy, he realized that why don't I use this in artificial intelligence? They were unable to do face recognition. artificial intelligence algorithms could not do face recognition.
Right.
But he looked at Hubel and Wissel's idea and he said, why don't I extrapolate the brain, which is a fantastic biological intelligence,
Absolutely.
the biggest biological intelligence, into artificial intelligence. So he extrapolated this idea into the computer, into the algorithm, so that the computer previously was processing all the data together. He started processing it at 4 different levels in the computer.
And that changed everything.
And that changed everything. And that's why when you look at your iPhone, you must actually say thanks to Hubel and Wissel, who started the whole idea with the brain, and then built it into artificial. And then, of course, Fukushima, who built it into artificial intelligence. And that's how, if you unravel the mysteries of the brain, you will actually be able to build the artificial intelligence in a much bigger way.
Wow.
That's how it's going.
Wow, so many analogies, sir. Time is brain, and wow. So how many people want to now become neuroscientists, neuroradiologists, neurointerventionists? So there are so many more career opportunities that Hastak sir has just opened for all the young doctors over there. So let's unravel more mysteries of the brain along with artificial intelligence in sync. Thank you, sir. I think that was an excellent summation of the whole field, and a very good forecast of what's coming up, which the youngsters can take on as career opportunities. So Keyur, what are you looking forward to becoming? What do you want to do your MD in? What do you want to specialize in? And what are the tools, channels, resources that you feel that are looking good, and you would encourage others also to use these and move forward?
So as you said, I'm a third year MBBS student currently, and I'll be moving into the final year in the next month. So once my internship is complete, I'm looking forward to giving NEET PG and hoping to get MD medicine in India itself. And my final goal would be to super specialize in endocrinology. And that's kind of a personal reason why I'm choosing that, because I lost my grandfather when I was very young, and he had diabetes. So it was like I was not extremely young because I knew what was happening, but all I knew that I want to treat patients. I want to make this better. I don't want people to die. And then when I grew up, my mother being my biggest inspiration in life, so she's a doctor actually. So she actually took me to her medical colleges, and she used to show me around. I realized that this is something I want to be, and this is where I will be in future. And then when I came across, I learned a little more about what diabetes is. Diabetes is something you don't have a cure. You can treat patients symptomatically, but there's no cure for it. And diabetes leads to multiple complications. So that is where I realized that this is the path that I'm going to take. And it's like doing this, like passing through MBBS, it's a complete resistance pattern, because 5 years cramped up 19 subjects, it is a big deal. And it's like, as you said, ma'am, we are the ones, we have friends who are earning by the time we're still struggling. So you require that kind of a determination, you require perseverance, you have to be focused on what you want. And at the same time, when you get such opportunities like Metropolis gave me for this. So this is one of the few tools that I've always been using, when you get the opportunity, you should seek it. And at the same time, Metropolis did one thing very good. It allows you to, use your innovation, and innovation nurtures cure. So this was the best opportunity that I think, get ever again. And one last thing that was, the concept of publish or perish. This is actually, a very ignored concept in our country, because research is something that is going to make students think a lot beyond their books, and that is, should be taught to students, because we have multiple platforms available. We have PubMed, ResearchGate, and etc. But we do not know how to use it. It took me time to actually figure out how this actually works, in spite of it being available. And in earlier times, students were not very keen about research, because we did not have connectivity, we did not have the resources available. But now everything is at the tip of our fingers. We just have to Google it. So that is something that students have to be taught, that this is everything is available, you just need to know how to use it.
Yeah.
That's all.
Very well said. Publish or perish. I keep on telling all my junior colleagues that publish, publish, publish. And I feel 3 things happen out of publications, to add to what you're saying, obviously. But first thing is that you study your own data.
Yes.
And nothing speaks better than data. It's only God who we can trust without thinking blindly. Everything else must have data. right? And only when you study your own data, you realize, oh, here is an area of opportunity, here is an area of innovation, here is an area that is still not going well, and maybe we need to look at this. And always a publication ends in a futuristic thing for that particular thing. So when you study something, you close it by saying, okay, this is fine, but this needs little more work, this needs little more cases, this needs little more, and that is how things evolve. And if you pick up 2-3 areas which you keep on following up, through decades, as sir mentioned, it will have its own story of evolution, and you will grow with it, because so I think publications are very, very important, but you cannot publish trash, so you have to do good research to publish. You have to publish it well, you have to know you have to study well, you have to do your good literature search, and whatever the content that you pick up, or the objective or the goals, which is also we help people in nurturing, because sometimes people, they want to do something but they don't know how to do it. And I think that is also very important. So you've given me a great idea. I think we could run a series of how to use these tools correctly, because I think there are very few people who know, and now these tools are fully accessible, and with internet all over the place, everything is accessible, but the usage is not. Like even for a simple iPhone or any smartphone, without taking names of a company, I don't think 80% or 90% people know all the applications of that phone. All of us still just use it for 3 basic things. So I think that's some wonderful things from a young upcoming doctor. Thank you so much, Keyur. So sir, last word from you. With an astute clinician like you, I think we just want to know more about how do you really use this clinical engagement, and how do you just become better clinician? If you could end this with that, it'll be great.
Yes, I think all my life I've been a clinician, so I love patients, I love medicine, and I love working with patients. The nicest thing is the smile that you get when the patient, the mother of the patient or the father of the patient, the son sitting outside the ICU gives you a smile that the patient has done well. So how do you approach clinical reasoning? The older one is the pattern recognition. So you just recognize a pattern and you say this is what the disease is. But having said this, I think the better way to do it is what is called the hypothesis probabilistic way of thinking. So what you do is when you see the patient, of course you take the history and you do the physical, which is the standard part.
Right.
And after that you make a hypothesis.
Right.
So you generate. So usually I'll tell my students, and I tell, this is what I've been taught is, as soon as you take the history, you should have a hypothesis.
True.
So you should have at least 3 to 5 differential diagnoses on what can produce this problem. And after the physical, you should be able to narrow it down. After that, of course, you can take a social history, occupational history, and so on, and take all the hunches and everything into your thinking and build a probabilistic model.
Right.
So you've done a hypothesis, then you build a probabilistic model. The probabilistic model is very important because it tells you, is this a high probability of this disease? Is this a moderate probability? Is this a low probability? Or is this a very low probability?
Right.
So when I see a stroke patient, that's how I do it. So high, moderate, low, very low. And this probabilistic model is very important because the probability that you put before you do the test is very important. That's how you choose the test.
Absolutely.
You don't choose the test unless you have put a probability into it. So if you have a high probability, so you're, as they call a priori, this is called a priori, or the pre-test likelihood.
Yes.
So pre-test likelihood of stroke is high, then of course you should do the MRI.
Right.
If the pre-test probability is very low, and you're thinking of Guillain-Barré syndrome, then you should do the nerve conduction.
Right.
So it depends on that. And it's very important for us to understand that the test, the limitation of the test is based on the a priori.
True.
So if your previous probability of the test is high, then you do a test with great specificity because you want a positive predictive value.
True.
And if your probability is very low, you do the test with great sensitivity.
Yes.
Because then you want to rule out the disease. So you want negative predictive value.
True.
So your test choice should be based on the a priori or on the probability or pre-test probability of the disease. So the post-test probability of the disease is equal to the pre-test probability of the disease into the strength of the test.
Absolutely.
And the strength of the test is based on the sensitivity and the specificity. So here is the model I use. So what I do is based on, so if I have a patient, and of course this is true, that common diseases and common manifestations are like 90%.
Yes.
Whereas if you have a common disease and an uncommon presentation, it comes to 9%.
True.
But if you have an uncommon disease and a common presentation, it's 0.9%. Yeah. And if you come to uncommon disease, uncommon presentation, it becomes 0.09%. So the drop in uncommon disease is very high.
Yes.
So even though what we read is mostly uncommon disease, but the presentation, the common things are common. Yeah. And you mustn't miss the common things. So it's very important for you to put the a priori, or put the prior probability of the disease and do the test accordingly. Don't do the test, because I always find that, the younger generation does too much testing, to my thinking, which is not a good idea. And especially in India, it's a poor country. It's not a country with... So I think you must do the test based on what is your a priori. What's your pre-test probability of the disease?
I couldn't agree more, sir. I'm so glad that you summarized it, and I think I should play it on loop for everyone after this, because I actually abide by this principle. And exactly what you said, when we in the laboratory side, as you said, the test has got various aspects. I always tell the juniors and my associates that, look, first arrive at your differential diagnosis, your hypothesis. Don't jump into adding the ancillary tests. So today we are flummoxed. There are so much happening, right, with the molecular genomics, ancillary tests. There are so much. There's no end to it. You can keep on doing. But are you going to be doing everything for everybody? Is it right? India is a resource poor country. Absolutely. You have only these many resources.
Absolutely.
Now, are you going to put everything for everybody? Then you're just wasting everybody's time and money.
Yes.
So better is that you first arrive at what you are.
Yes.
And think like a clinician. Always tell them, first you did MBBS, right? Before you did MD Path.
Yes.
And before you did a fellowship in oncopath or nephropath or molecular. Like I myself am an oncopathologist. So first think like a clinician.
Yes.
Arrive at this thing that at this age group, in this site, at this location, with this size, with this radiology, what is the differential?
Yes.
And then now only you are stuck with these 5 things.
Yes.
Now out of those 5, now think like an MD pathologist and rule out 3.
Yes.
That these are the only 2 that are possible because of your own skill set of pattern recognition, morphological assessment.
Yes.
And then after that, you only need probably 2, molecular test or IHC test or, biomarkers, serum markers to rule out, or confirm.
Yes.
So then you always have a rule in assay and a rule out assay.
Yes.
And then that's how you sort of close the case at the fastest time possible with minimum, resources possible.
True.
But if you just go blind and, keep on,
testing.
There's no end to it, and then you keep on doing all these tests.
You're confused.
And you're just confusing everybody. And sir, another thing what happens is, as you very rightly said, between common and uncommon, there is so much unknown still in science.
Yes.
So when you will do so many things, something will come out.
Yes.
And then you will go and chase a incorrect path.
Yes.
Just because it's positive.
Yes.
But it is not related to this. That is an incidental finding.
Yes, absolutely.
That also doesn't come out very well if you don't follow this approach.
Absolutely.
So I think I'm going to make a reel out of what you just said and share it with everyone of this theory, because I think what sir just said, I think has to be known by each and every doctor. Each and every doctor, no matter the specialty, no matter what you're doing, whether you are a clinician, a radiologist, a pathologist, or a molecular biologist, or an AI, algorithmic person, whatever you are, I think it's this theory that will help us serve more patients with the same resources in minimal time and actually, have that commando approach, as sir says. So I think, thank you so much, sir. It's been lovely. I personally have learned a lot in this MedTalk, and I'm sure all of you have learned. Thank you so much, sir. And thank you, Keyur, and all the best.
Thank you for being a great anchor.
Thank you, sir. Thank you.